So what is an arthroscope to the knee? Generally, the surgeon will make two small incisions on either side of the patient's kneecap tendon. These little incisions are about 1 centimetre in size, so in fact only big enough to introduce the instruments that are needed by the surgeon. So one of the incisions is used to introduce the arthroscope itself, or the camera, and the camera itself is no bigger than a ballpoint pen or a pencil, and the other incision is used to introduce any instruments that the surgeon might need to perform the arthroscopy or to perform the procedure on the day. So the first procedure we'll be talking about is the meniscal resection. We did talk about the menisci in the anatomy video, and just as a quick recap, the meniscus cartilages, both the lateral meniscus and the medial meniscus, are found within the knee joint and are positioned between the thigh bone, the femur and the tibia. They are basically shock absorbers. So these meniscus can be damaged through a number of causes. Sometimes it can be due to just a degenerative tear, where the meniscus over its normal aging process becomes weakened, and the patient may have put themselves in a position where the forces applied to those cartilages wasn't able to be sustained, and we get a tear in those cartilages. We can get traumatic tears in the meniscus, and these can often occur due to heavy weight-bearing forces, flexion or bending of the knee, and then a twisting motion. So the cartilages get caught between the thigh bone and the shin bone, and it's there that we can cause trauma to the cartilage. What's the surgeon trying to achieve? During the actual procedure, he'll go through those two little incisions, introducing the camera and also the instruments he may need to actually remove the component of the meniscus which is causing symptoms. Generally speaking, most surgeons are trying to salvage as much of the cartilage as they can. So they'll use raspers and cutters to try and actually remove only the segment of the cartilage which has been torn. Usually post-operatively, these patients are treated as a day case. They usually go home, weight bearing is tolerated. We generally send them home with crutches only because at the end of the operation the surgeon often finishes the procedure with infusing the knee joint with some local anaesthetic, and as we know, local anaesthetics makes things fairly numb afterwards, so we generally encourage people to take crutches home with them so that as that anaesthetic wears off, if they find themselves in pain or enough pain to cause them to limp, they've got the crutches to use those until they feel comfortable to walk without a limp. So as I said, it's trying to remove that little tear in the meniscus to hopefully then remove the symptoms pre-surgery. The second procedure I'll talk about is the meniscal repair. And we're seeing a lot more meniscal repairs in recent times due to the development of this technique. As it suggests, the surgeon is going in there to try and repair the meniscus cartilage. We tend to find that these tears can often be located within the cartilage that has a relatively small blood supply, but can be shown to have some potential for healing. So the surgeon will go in again through those small arthroscopy incisions, introducing the instruments specifically to repair those cartilages. They're very specialised instruments, and they usually involve putting 1 or 2, even 3 stitches depending on the size of the tear. And as I said, the surgeon is trying desperately to salvage that meniscus. And this has probably come about because through history, when we used to see arthroscopies in the early days, the surgeon would often go and resect the whole cartilage, and this would often then lead to the development of arthritis later on in the patient's life. So I think we're far more advanced now in trying to salvage these meniscus cartilages. So if a tear is repairable, we might find that the surgeon will use this repair process of stitching the cartilage together to try and salvage that cartilage. Post-operatively, most patients are treated weight bearing as tolerated. So again, going home with crutches until they feel they can comfortably walk without a limp. One of the restrictions we sometimes place on these operations is to limit the amount of bend of the knee or flexion of the knee not past 90 degrees. And we partly do this because we know the cartilage is put under lots of force and stress when the knee is bent further than 90 degrees. And due to the fact we have some stitches in these cartilages, often the surgeon wants to try and protect these stitches for a period of time. The next procedure we'll talk about will also involve the meniscus cartilages, and this is the meniscal root repair. We did discuss in the anatomy video that the meniscus cartilages are C-shaped. They tend to be attached at their root attachments on the shin bone or the tibia, one at the posterior root, which is at the back of the tibia, and the anterior root, and the rest of the meniscus is fairly free to move around within the knee joint to accommodate for knee movement. These little attachment sites are known as our root attachments. Posterior root attachment found around the back of the meniscus and the anterior root attachment. So when we're having a root attachment repair, this is a much more significant operation, as the surgeon is trying to salvage the whole meniscus. When the root is actually detached, it means the meniscus is literally free to move within the knee joint. These very unstable meniscus need to either be resected completely, as we know will lead to arthritis down the track. The surgeon has the skill then to try and repair that meniscus root. The significance of this is that post-operatively, most of these patients are non-weight bearing for a period of time. And the reason for this is, as we weight bear onto the meniscus, as you weight bear and the shin bone is pushed up into the thigh bone, as we said, the meniscus works like a washer. So as we weight bear through that meniscus, those root repairs are put under a lot of pressure. So you can imagine it sitting like a C shape, the weight bearing pressure pushes the cartilages outward, and that can detach the root repair. And these are one of the most important things to think about, or the differences between a standard meniscus resection or repair. The root repair is the meniscus repair that we must be careful with, and that is the repair that will have a weight bearing restriction to it. So the next procedure we'll be talking about is the chondroplasty. Again, this is a specialised arthroscopy to the knee, and it is this procedure where the surgeon will be targeting the hyaline or the articulating cartilages of our knee. We discussed in the anatomy video the articulating or the hyaline cartilage is the specialised cartilage that sits at the end of our bone. This articulating cartilage is about 3-4 millimetres thick, and it protects, as I said, the underlying bone. During the normal aging process of the knee, this cartilage can become brittle, it can fray, it can become detached. We can also find traumas to this hyaline articulated cartilage. This can occur through sporting activities where there's a pivoting or a shearing force placed across the knee, and we can actually start to rip off or delaminate portions of this articulating cartilage. We also can find that there are osteochondral defects. Some of these can be congenital in nature, some of them can be just anatomical abnormalities. And this is where the articulating cartilage is starting to delaminate again from the underlying bone. The surgeon will go in through the normal arthroscopy incisions. He'll highlight the area that needs to be cleaned up. We call it clean up because he will use specialised instruments to rasp away or polish, if you like, the surface of the bone and remove that articulating cartilage which is unstable. So it's a very important part of the operation in the fact that the surgeon will try not to remove too much of that articulating cartilage, because as we know, it has a very important role in protecting the underlying bone. So removing too much of that cartilage will basically speed up the aging process and potentially start to reveal that underlying bone. So this is a very important part of the procedure. The surgeon needs to remove just enough cartilage to achieve his outcome, but not to remove too much where we start to reveal some of the underlying bone. With an osteochondral defect where some of that cartilage is literally broken away, the surgeon can reattach some of that cartilage, or again he'll just resect some of the unstable cartilage that's located at the end of those bones. Post-operatively, most of these patients are weight bearing as tolerated. Again, going home with crutches until they can walk comfortably with a limp. However, it is worth looking at the post-operative notes with these chondroplasties, because if a surgeon has had to remove a large fragment of the articulating cartilage, either due to the aging process or a chondral defect that was unable to be repaired, in some situations the surgeon will place this patient with some weight-bearing restrictions. And this is due to the fact that he's hoping for a little bit of scar tissue to form in that area of the articulating cartilage that he's had to resect. So it's worthwhile reading the post-operative notes when you've seen a chondroplasty to the knee, just to make sure that we take into account any of those larger defects that the surgeon may have had to resect back. And just another procedure that the surgeon can do through an arthroscopy is the removal of loose bodies. We can develop loose bodies within the knee joint. These can occur because small structures of articulating cartilage may have broken away due to the aging process. They may have broken away due to trauma, and they've now become a loose body floating within the joint. Many of these loose bodies can locate themselves into areas of the knee where they don't cause any symptoms at all. However, there are situations where these loose bodies, as their nature, are loose and can move around the knee joint. This can cause pain within the joint and also locking of the knee joint. And so the arthroscopy can be used to remove these loose bodies. Again, done through the arthroscopy incisions themselves. The surgeon will use little catchers or graspers to grasp the loose bodies and pull them out of the knee joint. If it's a large loose body, then the incision or the arthroscopy incision can be slightly larger, and in this particular case the surgeon may need to put a stitch in that incision if he's had to make the arthroscopy incision slightly bigger than normal. So again, worthwhile checking to see if this is the case, as it may change the post-operative management. So these are just some of the more common procedures that are done via arthroscopy to the knee joint. There are many others that can be done, but this is pretty much will cover around 90% of the standard arthroscopy procedures we'll see at St Vincent's Hospital, Kew.